Welcome back to the deep dive. Today, our mission is really focused. We're going beyond just the standard textbook anatomy of the orbit.
Right.
We're aiming for that next level, the kind of precision that an elite professional surgeon needs. We're talking about the orbit and its adnexae. It's such a small area, but incredibly packed.
Absolutely. It's one of the most densely packed, functionally vital spots in the whole body. And today, we're essentially looking at the surgical maps, the technical blueprints surgeons rely on.
Blueprints, I like that.
Yeah, because it's not just where things are. It's about the implications,
Yeah.
right? Understanding those tiny margins, 5 millimeters meaning success or failure, knowing about the single point blood supplies, the fascial connections, all the things that dictate function long term.
So this is deep technical stuff. Our sources are aimed at real mastery. We'll be navigating that bony framework, tracing the frankly vulnerable blood vessels, and really detailing the surgical approaches. How do you get into those 4 quadrants? How do you reach the apex safely?
Exactly. It's about moving from just knowing the parts to understanding the strategy. Why this approach? What are the risks?
Okay, let's jump right in. The foundation first. The bony container itself, the orbit. People always say it's a pyramid, geometrically speaking, a quadrilateral pyramid. But that shape alone doesn't tell the whole story, does it?
Yeah.
What about its actual position? And how much can it hold?
Right. It is a pyramid, base facing forward. That part's obvious. But the crucial bit is the orientation. That base isn't straight on. It faces forward, but also slightly laterally and a little bit inferior.
Forwards and downwards slightly?
Precisely. And that angle, well, that dictates your surgical approach, especially when you're trying to get deep, towards the apex. And the volume, that's the real constraint. We're talking about 30 milliliters in the average adult Caucasian orbit. Maybe a tiny bit more, maybe less.
30 milliliter. Wow, and you think about everything squeezed in there.
Exactly. The globe itself. 7 extraocular muscles, not 6. 7 if you count the living, all those critical nerves, the vessels, fat, the whole lacrimal drainage system. It's incredibly dense.
It really puts into perspective why swelling or bleeding in there is such a big deal. Pressure goes up fast.
Catastrophically fast sometimes. There's just no room to expand.
Okay, so that's the container. Before we, break through the bones surgically, let's look at the first layers a surgeon meets. The eyelids. We need that stratigraphy down cold. Superficial to deep, what are the key layers?
Okay, starting outside. Skin, obviously. Then the subcutaneous tissue. And right here, there's a little clinical point. In some populations, particularly many Asian individuals, there's often a quite prominent fat pad in front of the orbicularis muscle.
The preorbicularis fat pad.
That's the one. It definitely changes how you approach certain aesthetic surgeries, like blepharoplasty. So under that subcutaneous layer, you hit the orbicularis oculi muscle itself, that striated muscle.
The blinking muscle.
Right. Then deeper still, you find the orbital septum. This isn't bone. It's more like a sheet of areolar connective tissue. Think of it as a barrier holding the orbital fat back.
Okay, septum as the barrier. And then finally, the rigid bits.
Then you get to the tarsal plates, the dense connective tissue plates that give the lids their structure.
And just above the upper tarsal plate, there's that smooth muscle component. Miller's muscle.
Yeah, Miller's muscle, or the superior tarsal smooth muscle, technically. It sits right on the conjunctiva and the upper fornix. It gives that little bit of involuntary lift.
But the main muscle for opening the upper lid, the heavy lifter, is the levator, right? Its aponeurosis is key.
Absolutely key. The levator palpebrae superioris, it does the primary work via this thin fibrous sheet, the aponeurosis. And understanding how and where it attaches, well, that's fundamental for function and for getting the aesthetics right, like the eyelid crease.
Let's focus on that attachment. You said it's dual. That sounds important for the crease.
It is. It's the critical link. So the main part, the aponeurosis, inserts onto the anterior face of the upper tarsal plate. That's the lever pulling the lid up. And this is the crucial bit for the crease, some fibers extend forward from the aponeurosis.
Forward, towards the skin.
Exactly. They pass between the bundles of the orbicularis muscle and insert directly into the dermis, right at the level where you see the upper eyelid skin crease.
Ah, so it anchors the skin.
Precisely. Functionally, it stops the loose skin and the orbicularis muscle from just sliding down over the lid margin when you open your eye. If a surgeon doesn't respect or restore those dermal insertions during, say, ptosis repair, the patient won't have a well-defined crease, or it might look unnatural, or the ptosis repair might even fail.
That makes sense. And the levator aponeurosis also interacts with the lacrimal gland through its lateral horn. How does that work?
Right. The aponeurosis fans out laterally, forming what are called the lateral horn. And this horn actually indents the lacrimal gland on its medial side. It creates a sort of waist dividing the gland into two lobes. The smaller, more anterior one is the palpebral lobe. Critically, this lobe contains all the tiny ductules that release the tears onto the eye. The larger lobe, sitting back in the bony fossa superlaterally, is the orbital lobe.
And that division matters surgically. For biopsies, maybe?
Definitely. If you suspect a tumor or inflammation in the gland, you ideally want to biopsy the larger orbital lobe. If you're digging around to the palpebral lobe, you risk damaging those crucial ductules, which could lead to chronic dry eye. Not good.
Got it. Avoid the ductules. And you mentioned the levator has deep connections, too, near the superior rectus muscle. That sounds like another potential hazard zone.
It really is. The levator muscle runs almost parallel to the superior rectus muscle, just above it. And they actually share a common fascial sheath. It's like they're loosely bound together.
Okay, a shared sheath. Where does that sheath go?
It continues forward with Tennant's capsule, which surrounds the globe. And anteriorly, this combined sheath inserts right around the upper conjunctival fornix, the deep pocket, where the conjunctiva reflects off the eyelid onto the globe.
Why is that insertion point so critical?
Think about ptosis surgery, or even complex strabismus surgery involving the superior rectus. If you inadvertently cut or disrupt that shared fascial sheath at its attachment to the fornix, well, the fornix loses its anchor.
So what happens?
On upgaze, the conjunctival fornix will prolapse downwards. It can bunch up, look cosmetically poor, and even cause irritation or interfere with contact lens wear. It's a known complication, often from not appreciating that shared fascial connection.
Okay, moving down to the lower eyelid. Things are different there, similar layers, but crucially, no levator muscle, right? So how does the lower lid get pulled down?
Right, no levator analog. The structure is broadly similar skin, orbicularis, septum, tarsus, but the retraction mechanism is different. It relies on fibrous tissue extensions coming off the sheath of the inferior rectus muscle.
Ah, so connected to the muscle that pulls the eye down.
Exactly. This fibrous tissue complex actually splits to enclose the inferior oblique muscle, another muscle down there, and then it all blends into the inferior suspensory ligament, which is often called Lockwood's ligament. That whole system, along with the inferior tarsal smooth muscle like Mueller's in the upper lid, provides the downward pull.
But it sounds less robust than the upper lid system.
It is. Much less robust. Which is one reason why the lower lid often shows aging changes first, or is more prone to retraction after surgery or trauma.
Now let's talk anchors. The medial canthal ligament, or MCL, holding the inner corner in place. It sounds simple, but you mentioned it's complex, involving different parts of the orbicularis. Why the complexity?
It's deceptively complex because it anchors the lids not just side to side, but also front to back onto the bone. The MCL is formed by contributions from the preceptal and protarsal heads of the orbicularis muscle. Each of those heads has a superficial part and a deep part.
Okay, superficial and deep components. Where do they attach? That seems key.
It is key. The superficial heads from both preceptal and protarsal orbicularis fuse together and attach fairly anteriorly, maybe 2 to 5 millimeters, in front of the anterior lacrimal crest. They attach onto the frontal process of the maxilla.
Okay, that's the front anchor. What about the deep heads?
The deep heads dive much deeper. They attach directly onto the posterior lacrimal crest, which forms the back wall of the lacrimal sac fossa.
So you've got this sling anchoring the tarsal plates both anteriorly and posteriorly across that whole bony groove. What happens clinically if that entire tendinous fixation gets torn off, say, in major trauma or during tumor removal?
If you lose that solid bony fixation, the orbicularis muscle, which wraps around the eye, is basically unopposed. Its constant tone pulls the inner corner inwards and forwards.
Leading to?
You see characteristic signs of failure. Canthal dystopia, the inner corner gets displaced, often downwards and outwards, or it looks rounded instead of sharp. The caruncle, that pink fleshy bit in the corner, gets hidden. And the whole shape of the palpebral aperture, the eye opening, becomes abnormal. It might narrow horizontally, measuring less than, say, 28 millimeters, or the distance between the two inner corners, the intercanthal distance, might increase.
And fixing that requires restoring both attachments.
Absolutely. Just reattaching the superficial part won't cut it. You need to reconstruct both the anterior and the deep posterior fixation to get a functionally and cosmetically acceptable result.
Okay, let's move inside the fortress now. The bony walls themselves, starting at the top, the orbital roof. Mostly frontal bone, right?
That's right. The roof is mainly the orbital plate of the frontal bone. Posteriorly, it gets a bit of help from the lesser wing of the sphenoid bone. Surgeons use the features on the outside as crucial surface landmarks.
Like the suborbital notch.
Exactly. The supraorbital notch, or sometimes it's a complete foramen, a hole. It's vital because the supraorbital nerve and vessels pass through it. Finding that notch tells you where those structures are. And maybe half the time, there's another notch, the frontal notch, found a bit more medially.
Right.
Less consistent, but good to know it might be there.
And also, superiorly, but more medially, we find the trochlea. We think of it as a pulley, but anatomically, it's more specialized.
Much more than just a simple pulley. It's actually a complex little sling made of connective tissue, cartilage-like tissue. It attaches firmly in a little depression called the trochlear fovea, right up there on the frontal bone, supremedially.
And it anchors.
It anchors the tendon of the superior oblique muscle. It provides the fixed point that allows the superior oblique to rotate the eye correctly. Because that function is so critical, any surgery up in that supremedial quadrant has to be incredibly careful to identify and protect the trochlea. Damage it, and the patient gets debilitating vertical double vision.
Okay, crucial structure. Let's swing over to the lateral orbital wall. This one feels like the strong side, the protector. What bones make it up? And why is the superior orbital fissure, the SOF, which is packed with vital stuff, relatively safe during standard lateral approaches?
The lateral wall is the thickest, most robust. It's formed by 3 bones. The greater wing of the sphenoid posteriorly, the orbital surface of the zygomatic bone, the cheekbone, laterally and anteriorly, and a little contribution from the zygomatic process of the frontal bone superiorly.
And the SOF sits between the sphenoid wings.
Right, between the greater and lesser wings of the sphenoid. And it's like Grand Central Station for nerves and vessels. You've got cranial nerves, 3rd, oculomotor, 4 trochlear, 6 abducens, the entire ophthalmic division, V1 of the trigeminal nerve, plus the superior ophthalmic vein all passing through.
Wow, that's almost everything controlling the eye and sensation, so why isn't it constantly getting hit during lateral orbital surgery?
2 reasons: depth and curvature. The SOF is actually surprisingly deep. It's at least 28 millimeters, often more, posterior to the frontozygomatic suture, that palpable joint between the frontal and zygomatic bones of the side.
28 millimeters is quite far back.
It is. And combined with a natural outward curve of the lateral orbital wall, most standard lateral orbital surgeries, like for decompression or removing a mass that's not right at the apex, happen well anterior to that danger zone. You'd have to be specifically targeting the deep lateral apex to really put the SOF structures at high risk.
Okay, that makes sense. Let's drop down to the orbital floor. This is the classic spot for blowout fractures. What's the main anatomical feature here we need to worry about, besides the thin bone itself? The inferorbital system.
Definitely the inferorbital system. The floor is mostly made of the orbital plate of the maxilla, the upper jawbone, with a bit of zygoma laterally and a tiny piece of the palatine bone way at the back. The key features are the inferorbital groove, which becomes the inferorbital canal, and finally the inferorbital foramen on the face below the rim.
And the nerve runs through there, but it's not just the inferorbital nerve itself, is it?
No, and this is the crucial point for complications. Inside that canal, before the nerve exits the foramen, it's joined by the anterior superior alveolar nerve, and sometimes the middle superior alveolar nerve as well.
The nerves that supply the teeth.
Exactly. They branch off the main inferorbital nerve trunk within the bone of the orbital floor.
So if that bone gets fractured, or if a surgeon is working aggressively on the floor, say for decompression,
you risk bruising, stretching, or even severing those alveolar nerve branches, along with the main inferorbital nerve. The result: the patient wakes up with numbness not just of the cheek, lower lid, and side of the nose, but also, very specifically, the upper lip and the front 3 teeth on that side, the incisors and the canine.
And that numbness can be persistent.
It can be. It's a very common side effect, especially after complex floor repairs, and patients absolutely need to be warned about it beforehand.
Okay. Also on the floor, anteromedially, we find something unique: the origin of the inferior oblique muscle.
Correct. This is a key anatomical exception. Every other extraocular muscle originates way back at the orbital apex, from that fibrous ring called the annulus of Zinn. But the inferior oblique starts right at the front, in a little depression just lateral to the entrance of the nasolacrimal canal.
So it's the only one starting anteriorly. Why does that matter surgically?
It means whenever you're operating on the anterior or medial orbital floor, you will encounter the origin of the inferior oblique. For very wide access, sometimes you even need to temporarily detach it from the bone and then carefully reattach it later.
Good landmark. Okay, finally, the medial wall. Thin, fragile, the lamina pepperatacea of the ethmoid bone. This area demands absolute precision. And that brings us to that famous surgical guide, the 24-12-6 rule. This sounds essential.
It is non-negotiable. If you do any surgery on the medial orbital wall, you live and die by this rule. The medial wall is the thinnest, made up of contributions from the frontal process of the maxilla, the lacrimal bone, that paper-thin lamina papyracea of the ethmoid, and a bit of the sphenoid body posteriorly.
And the rule helps navigate near the ethmoid foramina.
Exactly. It's a ruler, measured in millimeters, starting from the anterior lacrimal crest, ALC, that sharp bridge you can feel just inside the medial orbital rim. The rule tells you the approximate distances back to the anterior and posterior ethmoidal foramina. These foramina transmit the ethmoidal arteries and nerves, and critically, they mark the level of the skull base.
Okay, break down the numbers for us. 24, 12, 6.
Starting from the ALC, you go back approximately 24 millimeters along the medial wall, and you should find the anterior ethmoidal foramen. That's your first major landmark and danger point.
24 millimeters to the first one, then?
Then you go back another 12 millimeters from the anterior foramen, and you should find the posterior ethmoidal foramen, second danger point.
Okay, 24, then 12 more, and the last number.
And from that posterior ethmoidal foramen, it's only about 6 millimeters further back to the entrance of the optic canal, where the optic nerve enters the orbit.
Wow, only 6 millimeters. So adding that up, 24 plus 12 plus 6. That puts the optic canal roughly 42 millimeters posterior to the anterior lacrimal crest.
Approximately, yes. It's a guideline. Obviously, there's individual variation, but it's remarkably consistent.
And the consequence of getting that wrong. If a surgeon misjudges the ALC, or just gets lost by a few millimeters back there.
The consequences are catastrophic. If you think you're still over the ethmoid sinuses, but you're actually 42 millimeters or more back, you risk drilling directly into the optic canal and damaging the optic nerve, causing blindness. Or if you damage one of the ethmoidal arteries, right where it enters its foramen. Remember, these arteries come from the ophthalmic artery inside the orbit, but then pass through the skull base suture line into the ethmoids. If you tear one, it can retract back through the skull base.
Leading to intracranial bleeding.
Exactly. Potentially fatal intracranial hemorrhage. So the 24-12-6 rule isn't just anatomy trivia. It's a fundamental safety sequence for avoiding blindness and intracranial disaster when working on the medial wall.
Let's shift focus now to the life support systems, the blood vessels and drainage, starting with the retina itself. You mentioned a dual blood supply. Why is that advantageous? How does it work?
It's a fantastic design for resilience. You have the central retinal artery, the CRA, which branches off the ophthalmic artery and runs within the optic nerve to enter the eye. This CRA supplies roughly the inner two-thirds of the retinal thickness, primarily the nerve fiber layer and ganglion cells.
Okay, the inner two-thirds from the CRA. What about the outer third, where the photoreceptors are?
Right, the photoreceptors, the rods and cones, and the retinal pigment epithelium beneath them. This outer layer is actually avascular. It doesn't get blood directly from the CRA. Instead, it relies entirely on nutrients diffusing from the incredibly dense capillary network just underneath it, the choriocapillaris, part of the choroid.
So the CRA feeds the inner retina, the choroid feeds the outer retina.
Correct. And the fovea, the very center of our sharpest vision, is completely avascular, relying solely on that choroidal supply. This dual system means that certain diseases might affect one supply more than the other. For example, a CRA occlusion devastates the inner retina, but the outer retina might survive if the choroid is okay.
And the optic nerve head, where the nerve enters the eye. Does it share this redundancy?
It does, to some extent. The surface nerve fiber layer of the optic disc gets blood from branches of the CRA. But the deeper tissues of the nerve head get a significant supply from a circular arterial network around it, called the circle of Zinheller, which is fed by the short posterior ciliary arteries branches that also supply the choroid. So yes, there's overlap right at the nerve head.
This redundancy seems protective. You mentioned the anterior segment, the iris, ciliary body, cornea also has a good supply. But there's a specific surgical warning. Operating on 3 or more rectus muscles at once carries a risk. Why is that the threshold?
Yeah, the anterior segment normally has a very robust blood supply. It comes mainly from the anterior ciliary arteries. There are usually 2 for each rectus muscle, except the lateral rectus, which only has 1, and these anastomoses, they connect up with the long posterior ciliary arteries to form a network.
So plenty of collateral flow, usually.
Usually. However, those anterior ciliary arteries run with the rectus muscles before they pierce the sclera to supply the inside of the eye. So if you detach a rectus muscle from the globe during surgery, you are necessarily interrupting the flow through its associated anterior ciliary arteries.
Okay.
Detaching one muscle, no problem, plenty of collateral flow. Detaching 2, usually fine. But if you detach 3 or more rectus muscles in the same operation, maybe for very complex strabismus or severe thyroid eye disease, you risk compromising so much of the inflow from the anterior ciliary arteries that the remaining supply isn't enough.
Leading to.
Anterior segment ischemia. It can range from mild inflammation to, in severe cases, necrosis of the iris, corneal edema, cataract.
Yeah.
It can be devastating. It's rare, but the 3-muscle rule is a strong caution for surgeons.
Yeah.
You have to weigh the benefit of moving that third muscle against the potential ischemic risk.
A critical calculation.
Yeah.
Now let's get to what you called the single supply problem, the optic nerve's vulnerability, especially in the posterior orbit. This sounds like the biggest vascular Achilles heel back there.
It absolutely is. So, the central retinal artery, as we said, enters the optic nerve sheath maybe halfway along its course within the orbit, usually coming in from underneath.
Okay.
This means the anterior half of the interorbital optic nerve, the part closer to the globe, actually has a pretty good dual supply. It gets blood from the CRA running inside it, and it gets blood from tiny perforating vessels coming in from the surrounding dural sheath, which has its own rich plexus.
So the front half is relatively safe, but the back half.
Precisely. The posterior half of the optic nerve within the orbit, the segment closest to the orbital apex and the optic canal, relies predominantly on that single dural arterial supply from the pile vessels. The CRA is inside, yes, but the main supply to the nerve tissue itself back there comes from the sheath.
Meaning any problem at the apex.
Any compression from a tumor, any swelling from inflammation or surgery, any hemorrhage back there, it can easily compromise that relatively fragile pile blood supply to the posterior nerve segment. And because there's no good backup from the CRA in that region, the nerve is highly vulnerable to ischemia. This is the anatomical basis for posterior ischemic optic neuropathy, or PION, a dreaded complication of deep orbital surgery or trauma.
That clarifies the risk enormously. Okay, let's switch to drainage. The veins. Where does the blood go out? And how does that help diagnose problems?
Venous drainage mostly flows backwards, towards the orbital apex. The main collectors are the superior and inferior ophthalmic veins. They receive blood from the eye itself, including the 4 vortex veins that drain the choroid and from all the other orbital tissues. These main veins then exit the orbit posteriorly, mostly through the superior orbital fissure, to drain into the cavernous sinus inside the skull.
So if there's a problem back there, at the fissure or in the cavernous sinus,
You'll see the consequences in the orbit. Clinically, if you see signs of orbital congestion like ptosis, bulging eye, chemosis, swollen conjunctiva, maybe some dilated veins on the surface, and imaging, like an MRI or CT venogram, shows enlargement of the superior ophthalmic vein, it's a strong indicator of raised pressure downstream.
what could cause that?
It could be something blocking the drainage, like a mass near the superior orbital fissure. A classic example is a sphenoid wing hemangioma. Or it could be a problem in the cavernous sinus itself, like thrombosis, or maybe abnormal connections like a carotid cavernous fistula, or a dural shunt causing high venous pressure. Observing the orbital veins gives you clues about deeper pathology.
Very useful. Lastly, in this section, let's trace the path of tears. The nasolacrimal system. Essential knowledge for DCR surgery. Where does the journey start and end?
Okay, tears are produced by the lacrimal gland, wash across the eye, and then drain out. The journey starts at the 2 tiny openings on the eyelid margins medially, the superior and inferior lacrimal puncta.
Got them.
From the puncta, tears flow into short vertical segments called the ampullae, then turn sharply medially into the horizontal segments, the canaliculi, running within the eyelid margin.
Superior and inferior canaliculi, do they stay separate?
Usually no. In about 90–95% of people, these superior and inferior canaliculi fuse just before they reach the lacrimal sac, forming a short, common canaliculus. This common channel typically enters the side wall of the lacrimal sac about 4 millimeters below the very top, the fundus, of the sac.
Okay, common canaliculus into the sac, and the sac itself sits in that bony groove, the lacrimal fossa. Is it just loose in there?
No, it's encased in a specialized fascial layer, the lacrimal fascia. This fascia is interesting because it blends with the deep heads of the medial canthal tendon posteriorly, attaching to the posterior lacrimal crest, and anteriorly it attaches near the anterior lacrimal crest.
So the fascia lines the fossa. What does it separate the sac from?
Critically, anteriorly, the fascia separates the sac from the medial palpebral ligament, part of the MCL complex. Posteriorly, it separates the sac from the lacrimal part of the orbicularis oculi muscle, Horner's muscle. Understanding these fascial planes is key to dissecting down to the sac during DCR.
Any vascular landmarks to watch out for nearby?
Yes, a very important one. The angular vein, A continuation of the facial vein runs upwards towards the inner corner of the eye. It typically crosses the anterior surface of the medial palpebral ligament, about 8 millimeters medial to the actual inner canthal commissure, where the lids meet. Knowing its location helps avoid troublesome bleeding when making the skin incision for an external DCR. Hit the angular vein and it bleeds a lot.
All right, we know the structures, the vessels, the nerves. Now, how do surgeons actually get to them? Let's talk surgical approaches. When dealing with something deep in the orbit, like near the apex, there's this concept of the conoid of view. What limits the surgeon's view back there?
Yeah, the cutoid view is basically the surgical window. If you imagine looking through the orbital entrance towards the apex, you can only see a cone-shaped area. Theoretically, it's maybe 50 degrees wide horizontally and 30 degrees vertically, but in reality,
It's smaller.
much smaller in practice. Why?
Yeah.
Because you've got the globe itself in the way, you've got muscles you can only retract so far, and you inevitably get orbital fat spilling into your view, obscuring things. It's a real challenge working deep.
So how do surgeons improve that view? What are the basic strategies?
Fundamentally, two options. One,
Mm-hmm.
move your incision closer to the lesion. A more anterior approach for an anterior lesion, a more posterior approach, like lateral orbitotomy, for a posterior lesion. This reduces the depth you're working through.
Okay, move the entry point. What's the other option?
The other option is to physically make the container bigger. You displace one of the orbital walls outwards. And that's the main reason for doing more extensive procedures, like a bone-swinging lateral orbitotomy. You literally move the lateral wall out of the way to widen that conoid of view, giving you much better access to the apex.
Makes sense. Let's break down specific approaches, starting anteriorly in the upper orbit. A common approach is via the upper eyelid skin crease, often used for ptosis repair or removing superior masses. You make the incision there.
Yeah.
Then what's the absolute crucial safety step?
The step that prevents accidentally causing ptosis, making the eyelid droop. After you incise the skin and the orbicularis muscle underneath, you must dissect upwards for about 3 to 5 millimeters.
Upwards, towards the brow.
Yes. Upwards in the plane between the orbicularis muscle and the underlying orbital septum. Why? Because the levator aponeurosis, the thin sheet that lifts the lid, lies immediately deep to the septum or fuses with it superiorly. By dissecting upwards first, you create a safe plane above the aponeurosis before you open the septum. If you just cut straight back through septum right at the crease level, you are almost guaranteed to hit the aponeurosis.
Critical step. Protect the levator. Once you've done that upward dissection, how do you enter the orbit proper? What's the landmark?
Once you're confident you're above the aponeurosis, you make a small opening, a buttonhole, in the orbital septum centrally. The immediate structure you should see bulging through is yellowish orbital fat. Specifically, this is the extracornal preponderotic fat pad. Seeing that fat confirms you're in the right plane, anterior to the levator.
Okay, fat is the landmark, and the lesion is usually found within that fat.
Often, yes, if it's extraconal. You gently explore within the fat. If the lesion is deeper, intraconal, behind the muscle cone, you then need to carefully identify an incised tendons capsule, usually along the border of the levator superior rectus muscle complex, and gently retract those muscles to get deeper access.
Does the specific quadrant up there matter, superotemporal versus superomedial?
It definitely influences the difficulty. If you're going superotemporally, you have to work around the lacrimal gland, especially the main orbital lobe. Going superomedially, the big obstacle is the tendon of the superior oblique muscle, and critically, the trochlea it runs through. You have to be exceptionally careful not to damage the trochlea.
Okay, let's move to the lateral orbit. This area seems good for wider access flaps. What about a simple horizontal canthotomy, cutting the corner?
A lateral canthotomy, just a horizontal snip through the lateral canthus, possibly combined with cantholysis, cutting the inferior crest of the lateral canthal tendon, can give surprisingly good, quick access to the lateral orbit. It maintains the main lid fixation, bleeding is usually minimal, and it's great for biopsies or removing moderately sized lateral masses.
Downside.
You have to be careful not to damage the sheath of the lateral rectus muscle or the bulbar conjunctiva too much, or you can get adhesions later on, restricting eye movement.
For deeper lateral access, though, there's the lower lid swinging flap. That sounds much more involved. Describe that procedure.
It is much more involved, but it gives incredible panoramic access to the lower two-thirds of the orbit, right back to the apex. It's a workhorse for deep tumors or optic nerve surgery. It starts with a lateral canthotomy, but directed downwards, followed by full cantholysis. You completely detach the lateral aspect of the lower lid.
Okay, the lid is disconnected laterally.
Yeah.
Then what?
Then the critical internal incision is made in the conjunctiva, but placed way down low, along the lowest point of the inferior fornix, the deep pocket between the lid and the globe. This incision immediately enters the extracondylar orbital fat in the inferotemporal quadrant.
And you mentioned this is great for optic nerve access. How do you get intraconal from there?
The key advantage here is anatomical. To get into the muscle cone from this inferotemporal approach, you divide the intermuscular septum between the inferior rectus muscle and the lateral rectus muscle. And these two muscles happen to be the most widely spaced pair of rectus muscles in the orbit.
Widest gap means easiest access.
Exactly. It gives you the biggest natural corridor to approach the optic nerve, especially for biopsy or resection, with less need to retract the muscles themselves, minimizing traction on the nerve.
Makes sense. Now, there was a counterintuitive point about closing this flap. You mentioned not suturing the lower lid retractors. Why leave them be?
It seems wrong, doesn't it? You want to put everything back perfectly. But experience shows that aggressively suturing the cut edges of the lower lid retractors, that fibrous tissue connected to the inferior rectus, during closure, often leads to postoperative lower lid retraction or even entropion, inward turning. It creates too much scarring and vertical tension.
So letting them heal spontaneously works better.
Paradoxically, yes. Allowing the retractors to find their own level and heal by secondary intention generally results in a better long-term lid position and function. It's a case where less intervention is more.
Fascinating. Okay, still laterally, let's talk decompression for ptosis, like in thyroid eye disease. Lateral wall fenestration. How can surgeons remove bone there effectively but keep the outside looking good, avoiding canthal disruption?
The cosmetically preferred way is often through a laterally extended upper eyelid skin crease incision. This hides the scar well and avoids cutting the lateral canthus directly. The surgeon lifts the periosteum off the lateral wall.
And then removes bone. Is there a key technical point there?
Yes. The key maneuver during bone removal is to preserve an anterior bar of the lateral orbital rim. You don't take the whole rim out because that destabilizes the lateral canthus, looks bad. You remove bone behind this preserved rim.
Okay, leave a shred of bone at the front. Then what encourages the eye to sink back?
After the bone is removed, you incise the periosteum that was lining that bone. Crucially, you open the periosteum behind the arcus marginalis, that's the thickened edge where the orbital septum attaches to the rim. Opening the periosteum there allows the orbital fat to prolapse outwards into the space you've created in the temporal fossa, effectively decompressing the orbit.
Got it. Preserve the rim, open the periosteum behind it. Now, approaches to the orbital floor. Fat spillage seems to be a major concern here. You mentioned a high versus low lower lid flap. How does the high flap avoid the fat problem?
The low flap, as we said, goes right into the fat through the inferior fornix. The high lower lid swinging flap is often preferred aesthetically, precisely because it tries to keep the orbital septum intact. The internal incision here is different. It divides the conjunctiva and the fused lower lid retractors just below the lower edge of the tarsal plate.
Higher up, closer to the lid margin?
Exactly. By staying in that plane just under the tarsus, the surgeon effectively keeps the orbital septum, the barrier holding back the fat, intact below the incision. This dramatically reduces fat spilling into the surgical field, giving a much cleaner view of the orbital floor itself.
Cleaner view, less mess. What about the subciliary blepharoplasty flap? Incision right under the lashes. What's its advantage?
The subciliar approach involves that incision just below the lower lash line. Dissection then proceeds downwards, typically in the plane just on top of the orbicularis muscle, perceptual plane, down towards the orbital rim, often identifying the SOOF, the suborbicularis oculi fat pad.
And the advantage?
The big advantage is that it's the standard incision for cosmetic lower lid blepharoplasty. So if the patient needs floor surgery, like fracture repair, and they also have excess skin or baggy lower eyelids, dermatochalasis or fat prolapse, you can address both problems through the same incision. You fix the floor and then trim the excess skin muscle for a cosmetic improvement at the same time.
Efficient.
Yeah.
But regardless of the flap choice, high or subciliary, lifting the periosteum off the floor itself carries a specific vascular risk near the inferorbital canal, right?
Yes, that pesky inferorbital system again. When you're elevating the periosteum off the orbital floor, especially medially near the inferorbital groove and canal, there's almost always a significant little artery that runs between the orbital contents and the medial edge of that canal.
And it bleeds.
It bleeds reliably when you lift the periosteum there. You have to cauterize it meticulously. But the heat from the cautery, even when done carefully, is very close to the inferorbital nerve running right alongside it in the canal.
Resulting in
resulting in a very high likelihood of temporary numbness or altered sensation, paresthesia, in the distribution of the infraorbital nerve, that familiar pattern of cheek, lip, and front teeth numbness. It usually recovers, but it's an expected temporary side effect of dissecting the floor periosteum in that area.
Okay, moving to the deepest and perhaps most challenging areas, the apex and the medial wall. The retrocaruncular approach going in behind the caruncle, that pink bit medially, this is often called the gateway to the apex. Why is it so effective for getting way back there?
Its power lies in its direct posterior trajectory along the medial wall. It gives you surprisingly rapid and excellent access, not just to the ethmoid sinuses if you need them, but to the medial orbital floor and all the extracornal structures along the medial side of the orbit, right back to the annulus of Zinn itself, the true fibrous apex where the muscles originate.
All the way back, what's it particularly good for?
It's invaluable for things like inferomedial orbital decompression, especially in cases of thyroid eye disease where the optic nerve is being compressed right at the apex and you need maximal decompression posteriorly. This approach gets you right there.
The dissection plane sounds tricky, involving the periosteum. You mentioned the posterior lacrimal crest as a key landmark. Explain that transition.
Right. The initial incision is in the conjunctiva, just behind the caruncle. You then dissect posteromedially, staying close to the bone, underneath the posterior reflection of the lacrimal fascia. Critically, this initial part of the dissection is intraperiosteal. You are inside the orbit, within the extracolumnar fat, but still contained by the periosteal lining of the bone.
Okay, starting inside the periosteum, when do you go outside?
The posterior lacrimal crest, that ridge behind the lacrimal sac fossa, is the landmark. If your goal is just orbital decompression or accessing an extraconal medial mass, you might stay intraperiosteal. But if you need to do an ethmoidectomy, remove sinus partitions, or repair a medial wall fracture, you use the posterior lacrimal crest as your guide to deliberately incise the periosteum and enter the extraperiosteal space. Now you're outside the orbit proper, working directly on the ethmoid bone or the fracture site.
That switch is crucial. How far can you push this approach? What are the upper and lower limits?
The upper limit is strictly defined by those ethmoidal neurovascular bundles, the anterior and posterior ethmoidal arteries and nerves running in their foramina along the frontoethmoidal suture. Going above them risks skull base injury. That's the 24-12-6 rule territory again.
Okay, skull base is the roof. What about downwards?
Inferiorly, the dissection can sweep quite laterally along the floor, sometimes extending even past the inferomedial nerve if needed for very wide decompression. And for really maximal access way back at the apex, sometimes the origin of the inferior oblique muscle needs to be divided near the nasolacrimal duct entrance. Of course, if you cut it, you have to carefully reattach it at the end of the procedure.
Lots of flexibility there. Let's wrap up surgical approaches with a specialized one. External dacrocystorostomy, or DCR, creating a new tear drain. This isn't about removing tissue, but creating a pathway, right?
Exactly. DCR is all about bypassing a blockage in the nasolacrimal duct by creating a direct, permanent connection between the lacrimal sac and the inside of the nose. The most common approach is the external one, using a skin incision.
Where is the incision usually made?
Typically, a small, maybe 1 centimeter vertical or slightly curved incision is made on the side of the nose, about 8 to 10 millimeters medial to the inner canthus, overlying the frontal process of the maxilla. The first key step after the skin incision is to identify and disinsert the anterior limb of the medial canthal tendon, MCT, to get direct exposure of the bone underneath, which covers the lacrimal sac.
Okay, expose the bone. Then you make a hole, the osteotomy. How big does it need to be?
Size matters hugely in DCR. A small hole will scar over and fail. You need to create a large, bony opening. You start by breaching the thin bone near the suture line between the lacrimal bone and the maxilla. Then you enlarge it aggressively.
How aggressively? What are the boundaries?
Superiorly, the osteotomy should go right up to the level of the common canaliculus entrance, near the skull base, but not into it. Anteriorly, it needs to extend 8-10 millimeters onto the nasal bone itself. Inferiorly, it must go down to expose the beginning of the bony nasolacrimal canal, and posteriorly, it absolutely has to include removal of the posterior lacrimal crest and often the anterior ethmoidal air cells behind it. You need a wide-open window.
Massive window. And the final, arguably most critical step is connecting the tissues, the anastomosis.
Absolutely. The bone work is just preparation. The success depends on creating a wide, tension-free connection between the inside lining of the lacrimal sac and the mucosal lining of the nasal cavity. You make a large vertical opening in the medial wall of the lacrimal sac. Then you make corresponding incisions in the nasal mucosa exposed through your osteotomy, typically creating two flaps, a larger anterior one and a smaller posterior one.
And suture them together.
Yes. The key is to meticulously suture the cut edges of the lacrimal sac flaps to the corresponding edges of the nasal mucosal flaps using fine absorbable sutures. Anterior sac flap to anterior nasal flap, posterior sac flap to posterior nasal flap. This creates a wide epithelialized tunnel that allows tears to drain directly into the nose and resists scarring shut. That anastomosis is the whole point of the surgery.
All right, we've mapped the territory and the routes in. Now for the really advanced knowledge, the inherent dangers, the anatomical traps, the trade-offs. Let's start with the limits of decompression. You mentioned removing the orbital floor alone might not be enough for apex problems. Why is that anatomically?
It comes down to bony geometry again. The floor of the orbit is mostly the roof of the maxillary sinus, but that maxillary roof doesn't extend all the way back to the true orbital apex. The very posterior part of the floor is actually formed by a small bit of the palatine bone. This means the maxillary roof falls short of the apex by about 5 millimeters or so.
So taking out the maxilla leaves the deepest 5 millimeters untouched.
Exactly. If you have optic nerve compression right at the apex, purely from medial or inferior structures, just removing the maxillary part of the floor, a standard floor decompression, might not relieve the pressure on the most posterior part of the nerve. It's often insufficient for maximal apex decompression in cases of compressive optic neuropathy, forcing the surgeon to consider also removing the medial wall, which carries its own risks.
And speaking of removing the inferomedial walls, there's a risk of a secondary problem later. Imploding antrum syndrome sounds dramatic. How do you prevent the maxillary sinus from collapsing inwards?
Imploding antrum, or silent sinus syndrome, happens when the connection between the maxillary sinus and the nose gets blocked, often by prolapsed orbital fat after a large decompression. Negative pressure builds up in the sinus, and the thin bony walls gradually collapse inwards, pulling the eye downwards and backwards. Anaphthals.
How do you stop the fat from blocking the drain?
The key is surgical judgment during the decompression. You need to preserve enough bony structure medially to prevent excessive fat prolapse. Specifically, surgeons try to retain the anterior half of the bony strut between the maxillary sinus and the ethmoid sinuses, the maxilloethmoidal strut. Leaving this strut intact helps maintain the sinus outflow tract while still allowing decompression. It's a balance.
A structural trade-off. Okay, specific nerve hazards. The trochlear nerve, cranial nerve, the fourth. You said it's unique among the motor nerves in the orbit. Why is its path particularly risky when working supraronasally?
Its uniqueness is that it's the only motor nerve to the eye muscles that travels significantly within the extraconal space before reaching its target. CN3 and 6 enter the muscle cone right at the apex. But CNID enters the orbit, usually superior to the annulus of Zinn, then travels forward in the extraconal fat, running from lateral to medial across the top of the levator superior rectus complex, before finally diving down to innervate the superior oblique muscle from its orbital surface.
So it takes a long exposed route through the fat up there.
Exactly. Because of this long, somewhat vulnerable path in the supranasal quadrant, it can be accidentally stretched, cut, or cauterized during surgery in that area, even if the surgeon thinks they are working safely away from the muscle cone. Damaged CNIV, and the patient gets a superior oblique palsy, that troublesome vertical double vision, especially when looking down and in.
Good warning. We talked about the lacrimal gland earlier. What about damage to its posterior pole? You mentioned a potentially beneficial side effect.
Right, this is specific. The nerve fibers that control reflex tearing due to emotion or irritation enter the lacrimal gland at its posterior aspect, traveling at the lacrimal nerve. If this posterior part of the gland, or the nerve entering it, is damaged, the patient may permanently lose reflex tearing on that side.
But they don't get a totally dry eye.
No, because basal tear secretion, the basic lubrication, is controlled differently and usually remains intact. So you lose the overflow tearing, but not the essential moisture. Why is this sometimes useful? It can actually be therapeutic for curing crocodile tears or gustatory lacrimation, a condition where misdirected nerve fibers cause tearing when the person eats. Intentionally damaging those specific nerve fibers can fix that problem.
Interesting. Now, diplopia double vision. Why is the risk higher after removing the medial wall and floor, especially in thyroid eye disease patients, compared to removing the lateral wall?
It comes down to muscle mechanics and disease changes. In thyroid eye disease, the medial rectus and inferior rectus muscles are often the most severely affected. They become off. They become enlarged, fibrotic, and restricted. They are also inherently powerful muscles, dominant in pulling the eye medially and downwards.
So removing their bony support is riskier.
Yes. When you remove the medial wall and/or a floor, these already tight and enlarged muscles can easily prolapse or shift position into the created space, the ethmoid or maxillary sinus. Even a small shift or increased restriction in these dominant muscles can lead to significant, often intractable, double vision postoperatively. Lateral wall decompression is generally less risky for diplopia because the lateral rectus is less often severely involved and less dominant.
So the high diplopia risk makes inferomedial decompression a bigger decision.
Absolutely. It's often reserved for patients where vision is threatened by optic nerve compression, accepting that diplopia might be a significant trade-off.
Let's reiterate the most severe ocular risk. Posterior ischemic optic neuropathy, PION. Remind us why the posterior half of the nerve is the danger zone.
It boils down to that single dural arterial supply. The posterior interorbital segment lacks the robust backup from the CRA that the anterior segment enjoys. Its perfusion depends almost entirely on those small pile vessels fed from the surrounding dura. Any sustained pressure, inflammation, surgical trauma, or vasospasm right at the apex can compromise this singular supply, leading to irreversible ischemic damage to the nerve PIN and permanent vision loss.
Got it. Single supply equals high risk. And lastly, ciliary ganglion paresis. That little cluster of nerve cells in the orbit. You said damage is most common with the lower lid flap. What are the telltale signs and the critical long-term consequence?
The ciliary ganglion sits laterally in the orbit, between the optic nerve and the lateral rectus. It relays parasympathetic fibers for pupil constriction and accommodation, and carries sensory fibers from the cornea. Damage it, and you get several signs. A persistently dilated pupil, mydriasis, because the constrictor fibers are out. You might see vermiform pupillary contraction where only segments of the iris sphincter twitch weakly in response to light. Accommodation, focusing can also be affected.
Annoying symptoms, but what's the critical problem?
The critical long-term consequence is sensory loss to the cornea, a hypoaesthetic cornea. The cornea loses its normal sensation. Why is this so bad? Because sensation triggers the protective blink reflex and tear production. Without it, the patient is unaware of minor injuries, dust, or dryness. This puts them at severe chronic risk of developing a neurotrophic corneal ulcer, where the corneal surface breaks down simply due to the lack of protective sensation and trophic nerve factors. It can lead to scarring, infection, and permanent vision loss. Protecting the ciliary ganglion is crucial.
Wow, a numb cornea is a dangerous cornea. Good point. Okay, let's put all this incredibly detailed anatomy into practice with a clinical scenario. Imagine a 48-year-old man comes in. He's noticed gradual, painless vision loss in his left eye. Acuity is down to 612. He's lost color perception. Examination shows a moderate relative efferent pupillary defect, RAPD, on the left, and the optic disc looks a bit pale, suggesting early atrophy. But here's the thing. His eye movements are full, and there's no proptosis. His eye isn't bulging. What does that pattern scream?
That pattern screams intrinsic optic nerve problem, or something compressing the nerve right at the orbital apex behind the globe. The visual loss, the RAPD, the disc pallor, all point to optic nerve dysfunction. The lack of proptosis or motility restriction suggests the lesion isn't large enough yet to push the eye forward or restrict the muscles significantly, meaning it's likely located posteriorly, perhaps intraconal, right near the nerve.
Exactly. So he gets an MRI. The axial cross-section views show a well-defined, round, homogeneous mass. It's intraconal inside the muscle cone right at the apex, clearly pushing against the optic nerve. On T1 and T2 weighting, it looks isointense to muscle or gray matter.
Okay, classic appearance for something like a cavernous hemangioma or maybe a nerve sheath tumor located intraconal at the apex. But the axial view only gives you part of the picture. The sagittal view, side view, is crucial for planning surgery.
Right. And the sagittal view provides two critical pieces of information here. First, it confirms the lesion is located below the optic nerve. It's an inferior intraconal tumor. Second, it shows the ophthalmic artery. Where is it in this patient?
Okay, that's vital. The sagittal shows the ophthalmic artery, OA, passing over the top of the optic nerve just in front of the tumor. Now, usually the OA enters the optic canal inferolateral to the nerve, so seeing it riding over the nerve near an inferior lesion is a really important anatomical variant to know.
An inferior tumor with the main artery nearby, but superior in this case. Given this specific location right under the nerve at the apex, what are the combined major risks if you go in surgically?
The risks are significant and interconnected. First, direct mechanical damage to the optic nerve during tumor removal, causing further vision loss. Second, given its apical location, there's that high risk of posterior ischemic optic neuropathy, PONN, if the nerve's delicate dural blood supply is compromised by swelling or manipulation. Third, damage to the ciliary ganglion, which often lies inferolaterally, could lead to that permanent dilated pupil and the dangerous hypoesthetic cornea. Fourth, disrupting the motor nerves as they enter the muscle cone, right there at the annulus of Zen, could cause permanent double vision.
A minefield. So the preferred approach for an apical lesion like this is often a lateral orbitotomy. Why is physically moving the lateral wall outward superior for accessing this specific danger zone?
It comes back to that conoid view. For a deep apical lesion, especially one nestled right under the optic nerve, a standard anterior or even transconjunctival approach gives you a very narrow oblique angle. You're working down a deep, dark tunnel. A lateral orbitotomy, especially a bone-swinging one where you temporarily remove and replace the lateral wall, physically displaces that wall outwards.
Widening the angle.
Exactly. It significantly widens the surgical cone. It allows the surgeon to approach the apex more directly, with instruments coming in less obliquely. You get better visualization, more room to maneuver, and crucially, less need to retract the globe or the sensitive optic nerve and muscles medially. It converts a keyhole view into a wider window.
Makes sense for access. Now let's connect back to that specific MRI finding the ophthalmic artery hazard. The artery is nearby, superior to this inferior tumor. How does the necessary use of bipolar diathermy for controlling bleeding amplify the risk here? What's the diathermy danger?
This is one of the most feared complications. You have an inferior tumor, but the OA, the main blood supply to the entire eye, is draped just superior to it or nearby. Direct injury with an instrument is obviously a risk, but the insidious danger is from the heat generated by bipolar diathermy.
Even careful cautery.
Even very careful, low-power bipolar cautery used to stop tiny bleeders near the tumor. Or the optic nerve sheath creates localized heat and inflammation in that incredibly confined apical space. This inflammation can trigger vasospasm in the ophthalmic artery or its crucial branches supplying the optic nerve, like those posterior ciliary arteries.
And vasospasm cuts off blood flow.
Exactly. The artery clamps down. Given the precarious single dural supply to the posterior optic nerve, even temporary vasospasm induced by diathermy heat can be enough to cause a devastating postoperative visual loss due to ischemia, PION. The patient might wake up from seemingly successful surgery unable to see. It's a nightmare scenario, and minimizing diathermy use right at the apex, especially near the OA, is paramount. #outro.
Wow. We have gone incredibly deep today. From the precise insertions of the levator aponeurosis that create the eyelid crease, all the way back to that critical 42mm boundary marking the optic canal using the 24-12-6 rule. It's clear that mastering this anatomy is everything.
It really is. Understanding these minute relationships, the threshold for anterior segment ischemia with 3 rectus muscles, that single dural supply making the posterior nerve so vulnerable, the safe plane above the levator, that's what transforms surgery from just risky cutting to informed, precise intervention.
And recognizing the limitations, too. Like, knowing that just removing the orbital floor often isn't enough to truly decompress the apex, that it falls short by those crucial 5mm.
Exactly. Success is often about acknowledging those anatomical constraints and understanding the functional trade-offs. Every approach, every decompression has potential downsides.
Which brings us to a final thought for you, the listener. We've seen the intense risks associated with operating at the orbital apex, the high chance of diplopia if dominant muscles prolapse after wall removal, the ever-present danger of ischemic optic neuropathy. So, when faced with a posterior compressive lesion, like that tumor under the optic nerve we discussed, beyond just avoiding the nerve itself in the major vessels, what other specific anatomical structures, maybe fascial planes, maybe smaller nerves like the ciliary ganglion branches, would you prioritize preserving above all else to minimize that long-term functional and sensory loss? Knowing that a numb cornea or persistent double vision can be almost as debilitating as vision loss itself.
That calculation balancing maximal tumor removal or decompression against preserving intricate function, that's the core challenge. What risks are acceptable? What structures are non-negotiable?
Definitely something to ponder. It highlights that elite surgical skill is as much about knowing what not to disturb as knowing what to remove.